long time. I wanted to start out just kind of with my story, like I happened to get an ileostomy and how this all started. In 2005, I had a hysterectomy. Some of you have heard this already a little bit in small pieces. But I went for a post-op appointment at the clinic, the OBGYN clinic, and it was a clinic in Regents Hospital in an older part of the hospital at that time. And I was having an examination. I had a clot around the cervix. So the doctor said, we need some peroxide to break the clot down and to flush that out. And I said, well, I don't think that's a good idea. You're not supposed to use peroxide internally because it burns. He said, well, we do this all the time. So he put a 60 cc syringe on a Foley catheter like this, pushed it up near the cervical cuff, and there's a small incision in there into the peritoneal cavity. Well, he was advancing it, and I don't think he later did not know that he was through that incision, and he flushed the peroxide full strength into my peritoneal cavity. So at that time, I had a lot of pain, right referred shoulder pain. I talked to some of you about that, where any intrusion on the abdomen, free air, or some kind of toxicity in the abdomen, you got this immediate right shoulder pain. And they said, well, we're going to have you lay down. You should be fine. We'll take the catheter out. Just get up and leave when you feel better. And the clinic had ended at lunch. Well, nobody knew that I was still in that room. So I remained in that room for about 2 hours. I collapsed while I was getting dressed and was in shock, found in shock in the room. And then brought down to the emergency room, and there was a lot of confusion. So about 6 hours later, the peroxide was removed during an emergency laparotomy to rinse out the peroxide. And it was, when they opened me up, it was brown, or a gray foam that was just pouring out of my abdomen. So I was in surgery for about 4 hours. So very painful. Couldn't really advocate for myself. I mean, people kind of left the clinic and thought I was going out on my own. I don't think they stayed with me long enough to find out if I was okay. They just thought I was having some burning from the peroxide, and I tried to tell them that I really felt awful, but things kind of fell apart real quick. And I don't remember some of it. I remember waking up and having somebody find me there. So anyway, you have to stay with your patient till they're stable. Yeah.
Like a housekeeper find you or something like that?
No, it was another nurse in a clinic down the hall heard me screaming.
Oh, wow.
And came in and found me. And I don't remember this, but she told me I was holding pictures of my kids saying that I was going to die.
Oh.
So I had both my kids' pictures in my hands. I don't remember it. But she actually came up to see me in the ICU and was tearful about the whole thing. She felt bad that that happened. So I must have felt like my life was going to end because I was alone. So anyway, I had the surgery. Then between 2005 and 2012, just constant problems with constipation. So I would take like 10 to 12 Duplex tablets a day. And just lots of cramping with that. And I had to basically, my colon was not functioning so much to the point where I had to have the stool liquid to get it out. I mean, there was just no muscle tone, no ability for the colon to work. So then by 2012, it was decided that a little part of my colon was twisted maybe, so they wanted to remove that and then do a temporary ileostomy to see how I would do. Remove that part of the colon, then hook it up temporarily and give that part of the gut some relief, and then reconnect it later. So what happens is that the colon just gets to be, this is all full of stool where the stool backs up, you can see the area. And my colon was like that. It became very big and fatty and just huge where there was no muscle tone to it all. And they did take out a portion right here of my colon. Some of it was twisted.
Is that like a medical?
Yeah. Yeah, that's what happened. Sorry about that. Okay, so this is an end ileostomy. This is what I have right now. This is a loop ileostomy, and that's a temporary one. If you want to go to the next one, I might go back to this one. Okay, so the loop ileostomy has two openings because you have the small intestine and the large intestine. So why they do that is they're going to, when they reverse it, they're going to I was gonna say glue it back together. No, they're gonna take and sew that back together and drop it in. And so it'll function again. So that's what I had with my temporary ileostomy. It's, some people keep them permanently, but they're not really good to put an appliance around because they're irregular shaped. They're hard to find an appliance that fits them properly, and it's hard to get a hole cut around those to keep them from leaking. So I found that it was real difficult. And then the large intestine part just is leaking mucus all the time. So you have constant mucus coming in along with the ileostomy stool. So I found that it was kind of hard to deal with, you know.
Go back here to.
Yeah, so this end ileostomy is what I have now. They took a lot of my colon out, and then and this is much easier to deal with. But that works perfect for the temporary. And then, of course, the ileostomy is the liquid stool, and then your colostomy is the larger stoma with the harder stool. Okay, so when I had the ileostomy reversed to give me a trial on how I would do, I ended up, actually when they reverse that, there's a tiny hole that granulates. They pull it together with sutures. I had a picture of that, but I can't find it now. But there's a tiny little dime-sized hole in your abdomen, and they pull the sutures together, and they leave that hole there, and it granulates on its own. But what happened in my case is I ended up with a wound, a deep wound that abscessed, and I had to pack that with this string packing. I think you guys have seen this. I keep packing that. So that took about 2 or 3 months to heal.
How deep was it?
It was probably, well, it went down real deep right in here, probably a ½ inch in here. And then it was more surface around here, but there was a pocket that I had to go into.
What caused that?
I'm not sure, it just did not heal. It didn't heal right, and it just got worse and worse, more and more infected. I certainly was cleaning it well. Yeah, here again. I think it's a risk. I think the reason why it happens is a risk because anytime you have a skin area that's open to air, and you know, they had that hole there, and it was open, and you're in the hospital, I think there's always a risk of infection for that. And they left it open. I mean, I didn't have it covered in the hospital. They wanted it to dry and left open to air, but I think that's a double-edged sword because you can get an infection like this.
Which is interesting, the thyroid completely was closed together, he had a loop.
Yeah. Yep, mine was a, you know, when I find that picture, I'll show it to you, but it's kind of interesting because there's a hole there that they leave open. And also, I think another thing is there was some sutures that got, I have an allergy to sutures, and some of the sutures did not dissolve correctly. And that might have started it too.
Yeah, sure. Did that hurt? Was it very painful?
That, yes, it was painful. Yep. And it required, so then after that healed, ended up with the same problems, lots of Dupalox tablets. And you know, when you have to take that many Dupalox tablets, you're having to take sitz baths because you're not getting to the bathroom in time and you're incontinent. I was constantly having accidents. It was just miserable. I feel way happier having a bag than you wouldn't think that, but it was so awful to have the cramping and be trying, and then you didn't want to eat because you're trying to move this stool through all the time that's just sitting there. So those same problems started to come back.
2 years? For 2 years that you had to live with doing that?
Doing what?
With this whole.
Well, from 2005 to 2012, I did the Dupalox tablets, yeah. Yeah, that's hard to live with.
Why so long?
Well, you know, it's a big deal to have an ileostomy. It's a big deal to have your, they saw slowed down transit with the barium swallows and were evaluating, but they didn't feel that it was enough. They said that I still had some function where I didn't need to jump to this extreme. So I was reluctant to do anything surgically until I absolutely had to. Okay, so then I went in and had a permanent ileostomy placed, and I think that was in 2013. Yeah. So this is the stoma I was talking to some of you about. So I got out of surgery, and you can look at the color. I mean, the color is dusky. So you go to the next one. Yeah, so there it is again. That's a really dusky stoma, and that's a stoma that you really need to be careful of. So I talked to my nurses, I talked to the doctor, I said, hey, you know, I don't know, I think the color isn't good, it's dusky, I'm worried about it. Oh no, they can look that way, and they sent me home with that. So then ultimately, and then I got, this the same one, dusky, and I got a little infection for a suture here, and that really is, gets deep when your suture gets infected, so I had an abscess there. So that's what happened when I got home. So about a week to 2 weeks later, it turned black. So it's interesting how, you know, I talk a lot in these, classes about advocacy, advocating for your patient. You know, the nurses weren't advocating for me at the hospital. I was discharged home when that was dusky, even though my gut told me it wasn't okay. Then I couldn't get an appointment. Oh, well, you know, we'll see you in another week. I lived in St. Cloud, so I had to travel to the Twin Cities, tried to get an appointment, and it was very hard to get in. And, you know, everybody was kind of, well, then, when they saw it, when I came in, everybody's running all over taking me to surgery when they were thinking it was no big deal over the phone. So that required emergency surgery that night. And what happened was they, I thought they were going to replace it, but what they did, unfortunately, I wish they would have done this, but they burned off the black tissue with a cautery. Burned it all off, and she felt that there was enough blood flow that we could still have a stoma. But the problem is that when they burned that black tissue off, the stoma became hard. And then I could not, and then it recessed. It would come in and out, and it would become hard, and then I had to drain it all the time. This went on for several months. Draining it, and I had to take a syringe and stand over the sink and pull out the stool because it wouldn't drain. And then I would have bowel obstructions, and it would back up. I would have, is it the next one? Yeah, that's what I would have basically, is projectile vomiting, and then my bag wouldn't empty, and then I was trying to lavage so I went on for 3 months like that, 2 or 3 months, and the doctor didn't want to go back in. They're like, oh, well, you know, it'll open up. I'm like, no, this isn't going to open up. This is permanent. I knew it wasn't going to get better. So, there's my dog. Jeannie. Just a little interruption. Case study too, actually. She came from a puppy mill. Someone kicked her and shattered all her ribs, and she has 1 lung. So when I was sick, we healed together. I adopted her when I was sick, and I took care of her, and she took care of me. So. Okay, now that's a nice. Now when they went, I went back in, and they decided to just take and redo the whole ileostomy, and take the other one down and put the new one in. So this is what a nice, healthy ileostomy should look like, and that looks good. Now, there's a whole healing process. Remember I talked to you guys about getting patients hands-on. You know, you can tell if they're too sick to do it, but honestly, you gotta get them hands-on. Their survival counts on this at home with this. You need to do a lot of good wound care with this. So that was the beefy red one is right after surgery. So here's how this tissue changes after surgery. There's a whole film, and there's a whole process of how it changes. You can go to the next one. So there's, you know, you can develop an abscess from the suture. This whole thing sloughs. Go to the next one. Okay, this is after I got home. Look at that. Look at all this. That's all that healing process happens at home. So when you think about your patient, you really got to get them up to speed on taking care of that. I'm sorry, am I in the way for you guys? You got to get them up to speed on good care with that ileostomy. And I think the only way you can do it is get them Get them hands-on. I mean, give it to them, show them how to cut it. And if you're having problems, you need to talk to the stoma nurse or talk to the doctor. There's a lot of people that are young people that can't face this. I could because I was a nurse and I knew what it was about. I did it all myself. They didn't even have to help me. But that's rare. So if you have a patient that's like, I don't want to deal with it. I had a friend of mine who I was going to show her everything because she was getting an ileostomy. She's like, I don't want to know. So you're going to have patients like that, and they're real tough to deal with, but they're going to get infected, and they're going to have that whole thing redone if they don't pay attention to it. Because that has to be cleansed well. You got to cut the appliance properly around it. You got to use the proper adhesives and creams and ointments to keep it clean.
Was this where you had some irritation from the appliance?
Yes.
Yeah.
That's when I started using the disc. You see that on this, where it's cut around here, sometimes the stool leaks around it. So I used the disc after I started having some of this problem, and some of this is fungus too. But this is with good care. I mean, daily care is, look at how that's all morphed and changed in a different shape, and there's tissue sloughing away, and there's new things happening here. You can go to the next one.
And the sloughing is good, right? Like,
Yeah, the tissue
to an
changes.
untrained eye, that's
It's
going to
getting
look
used to
bad.
what's happening is, usually it's in the gut. It's going through the outside air process, you know? It's being exposed to things it hasn't been exposed to, and then this just starts to slough away as part of the healing process. So again, back to the patient, get them hands-on as quickly as possible. If you feel like they don't want to do it, that's a problem. Then you need to talk to the doctor and say, you know, we need to get site involved, or we need to have a support person come talk to them, or the stoma nurse needs to come up. The stoma nurses are helpful in marking the site before surgery, exposing the patient to different appliances at the hospital. They'll bring up all the stuff that they need and give them some supplies to take home. But your role is to get them ready up here and get them ready doing it, and just, you know, really push them to do that on their own. And then you're going to be able to see what they have trouble with when they're doing it. Okay, so during this hospitalization, I'm going to talk a little bit more about advocacy for your patient, because I believe very much in that. But during that several days after surgery, okay, now look at me. You know, I'm kind of thin. That was edema I got gradually in my legs. Okay, so I talked to my nurse and said, and my abdomen was huge. And I said, you know, I feel swollen, my weight went up like 5 pounds. And I had all this fluid, and I said, what's that from? And I got really nervous about it. Well, then what happened was I started having trouble breathing. I couldn't breathe. I was taking half breaths. I couldn't take a full breath. My incentive spirometers went from 2,400 to 1,000. And then when I would walk to the bathroom, I was like this. I couldn't sit up straight because my abdomen was hurting so bad. So I kept, for 2 days, I went on that way and asked the nurse, you know, and then they checked my SATs. The SATs were like 88%, and they were kind of wondering if it was the equipment. And then they go get other equipment, check it. Then the temp was 99.4, then 100, then 101. So there's people just not believing there's a problem with all those things going on. So you can see there's an infection process going on here. You have a fluid shift going on here. There's an infection somewhere. And what I found out 2 days later was that I had a rather large size abscess in my abdomen.
That you couldn't see from the outside?
Well, you could see that I had a bunch of distension.
Okay.
I was just swelled up, all this edema, not able to breathe, my SATs are down, my temp is up, and there was just this slow movement to a conclusion. And what was scary for me is, even though I was saying, hey, that's not right, I got a temp, I can't breathe, I got all these complaints, people are just kind of, well, we'll check it again in a couple hours. And we went on for like that for 2 days without anybody really, you know, the doctor should have been called, there should have been some kind of CT scan. But the nurse, you guys are the squeaky wheel for that. You know, get on those things, subtle changes. I shouldn't have SATs 98%. You know, I mean, that's kind of not good. I don't have any respiratory problems. I don't have COPD. So that should have been included, that nurse, that, hey, we need to deal with this.
Was it because, like, you had a PCA without a basal rate? So was it pain control, so hypoventilation, or was it the pain of the abdomen? That's
It
why
was
you're-
both. Another problem I had was, you can go to the next one. So when I went to interventional radiology at midnight, they decided, okay, there's something wrong. So, and I really see it as the nurses not getting on this, you know, rattling the cage with the doctor. So I had the JP drain, and then what happened in interventional radiology is I always tell people, okay, this looks like a simple little, you know, rubber thing, right? Well, they go into you with this big long harpoon with a corkscrew on it into your abdomen, right into that abscess. I never had so much pain in my life.
Gosh.
And you end up with this, looks like nothing, but when you're down there, they're putting this great big harpoon type, you know, into you, and it's very painful. So when I got back from surgery, I had horrible pain, and again, you know, I had nurses going, well, you know, I'd say, you know, my pain's about a 6 or a 7. Yeah, well, you can get something in about 3 hours. And then they leave the room. It's not our job to be the pain pill police at all, really. You want to keep that patient comfortable because you want them breathing better. You want them moving better. You want them to be comfortable enough to start moving so they don't end up with post-op complications. So the nurses that were on top of things were like, you know what, that hasn't worked, I'm gonna go get something more for you. And then if that doesn't work, we're gonna do something else. So follow that pain, follow that, you know, that pain scale was made to make sure that we're treating pain. We don't leave patients at 6 or 7 for pain. That's just unacceptable. And make them wait till the next dose. I know in nursing you get busy, you know, you get busy and you don't have time to call the doctor, but you really have to because you're gonna end up with some of the problems I had if you don't get patients moving. So this is all really painful. I mean, you've got that going on and, you know, people are gonna need extra pain medication. And then I ended up on a pump. And then one thing is they didn't have a basal rate going and then I was kind of honking out.
And
And so-
sometimes you have family there that might wake you to press the button, right? But you were alone.
Yeah, I was alone. Oh, one thing I forgot to bring up, you know, you guys, that first surgery, that temporary, you know, ileostomy, I had a psychosis, basically. So I had no family there, I was by myself, no one I recognized, and I was reported to be ambulating in the hallways crying. And I had confusion. I didn't know where I was, what was going on. I knew I had surgery. I didn't know the day, I didn't know the time. And it was the most awful thing I'd ever went through. And when I got out of the hospital, I couldn't remember. I knew I had the ileostomy. I don't remember anything that happened. I remember nurses trying to put an NG tube down and holding me down because they were trying to get it in and it wouldn't go in and it was going through my mouth. So I remember a lot of that. I remember that I had an ileus and they needed to do IV fluids. But I don't remember a lot of that hospitalization. It was like 10 days. And that's that psychosis that can occur with people in the hospital. That was really scary because nothing was familiar to me. I felt kind of lost and I didn't know what happened before me or after the surgery or anything. So that's real, that can commonly, and I'm younger and I have that. So.
What do you think would have helped you?
That's confusion. I wish someone would have dealt with my confusion and said, you know what, let's find some family to get down here. We need to get her oriented to what's going on. Because when you have a patient walking through the halls crying and they don't really kind of know what's happening, they probably need to connect with a family member. So, you know, they could have maybe, or even put somebody on the phone with them. Hey, we got to get some more support going on here for this person. Is there some family we can have them sit at the bedside? Because no one looked familiar to me. I felt completely lost. So
this was kind of purulent
Yeah.
drainage serostigmatus. And this one.
yep, that lightened up. So it gradually got lighter and lighter. I had this in for about 4 days or 5 days, then it was pulled. And I had an increased white blood count with that too. So diet, we talked about that a little bit, is, low fiber, low roughage. And the carbohydrates, like I said, they empty really fast, so I tend to eat those in the evening when I'm home. Protein is really good, but obstruction is a real big problem. I mean, I obstructed this twice with foods I was liking and wanted to try. And what I try to remove the obstruction myself with introducing some fluids in here and then kind of pulling it out. But a couple times I wasn't successful, so I had to go in. So that's why I'm very careful about what I eat. And every patient's going to react differently. You know, some people may like carbohydrates, some people may not be able to process protein very well. Just for me, that's what it is. But definitely with this ileostomy, you've got to stay away from roughage, lettuce, nuts, seeds, and popcorn, and raw vegetables, raw foods.
So how much weight have you lost?
About 30 pounds. Yeah.
Over the last year?
Yeah.
She lost her hips sitting at your shoulder.
Yeah, you could always see my hips like just going down. Yeah. Even at that last class I did, I'm bigger on that video. Yeah.
Is the weight loss due to the change in your diet or due to the absorption?
Probably the change in my diet. I'm just so structured about eating. I will not eat during the day till like 7 or 6 that night. I just won't.
If you're going places.
If I'm going places, and I really have I'm very structured about my eating because of my lifestyle. And then in the evening I'll eat, but then I eat kind of low calorie, kind of just protein. I don't get into a lot of carbs, so I think my diet's real limited. I probably don't take in more than 1,500 calories a day. Maybe 2,000 if I have some ice cream or something. But
I have a question. So then, do you not get very hungry then? If you can go all day, literally, without eating?
I don't get very hungry. I don't get hungry until I think my stomach is kind of shrunk up. The other thing is I was a big workout fanatic. When I ate real well, I don't work out as much now because my immune system is weakened. So I can't work out like I used to. I used to run like 5 miles a day and stuff like that. I can't do that. So I just kind of do walks, quick walks, but I don't get into a lot of aggressive working out because I don't think I take in enough nutrients to sustain that. So.
Are you on supplements and things?
I do I'm sorry, you're right. Okay, I have a protein powder that I use that has a lot of vitamins in it, but pills will not dissolve, so they just go into the big. So I usually would have, if I took a medication, I'm not on anything right now, but if I took a medication, I would crush it. And another thing, one thing you don't know about that happened with this whole thing is that I got when I had the first surgery, emergency laparotomy. What do we have a lot of in the hospital, you guys?
MRSA?
No, well, that too. C. diff. C. diff. I had it 3 times. C. diff. Could not get rid of it. I was on lactobacillus acidophilus for like 2 or 3 years, maybe 4 years. And that is, you guys, I don't know if any of you have ever had that. That is horrible. It is so painful. You are running high fevers. Your stool is pus. I mean, just pooping pus. I was so sick from that for like just a month to, 2 months being, recovering from that. But that's from that those antibiotics I had for the peritonitis. I was sick for like 3 or 4 years, kept getting C. diff. And I knew when I had it. It's kind of funny because I knew when I had it, but the laboratory kept saying, oh no, we don't see any in your stool. I go, no, I have it. I have it. Give me another container. I'd go home, I had it. Because each day you go on with that C. diff, you get worse and worse. And you can end up in the hospital with it because you get such a high fever and so sick. That is really an awful.
And the cramping, right?
Oh my God, the cramping's terrible.
Stool after stool after stool.
Fevers, stools, yeah.
So, where did you retire from the VA in this timeline?
2009.
Okay.
Yeah. started to have a lot of my problems started ramping up, and it got to the point where I really couldn't work full time, so I did retire. And then my mother was dying at the time of Alzheimer's, so took care of her and that, so that's when I retired from work. But I've been just working in the last couple of years now. So we went over appliances. So on appliances, you guys, there could be the one piece or the two piece. Now here's a couple of one pieces. This is an old fashioned kind. It's got the Correa ring, which is from the what tree?
Some tree in India.
I don't know, some tree. You knew that, didn't you? Did you look it up?
Yeah,
Oh, you can't.
it's some tree. but-
Okay. It's the Correa tree.
Is it like
So-
a rubbery substance? Rubbery kind?
Yeah, it is. It's like, yeah, rubber. It's
Okay, I saw that
kind
when
of
I
a
was-
waxy kind of thing. I'm just gonna pass these around to you guys. That one is an older one, but it's used quite frequently, and that's a one-piece system. And then this is another type of system with the, I like this kind where you can just, what I don't like is, now these are used more for colostomies because of course you have a lot larger stool coming out. But with an ileostomy, these aren't really helpful because you got all this stool, you're full of stool all the time. You know, you're trying to clear that out, you gotta use a lot of paper towels and you gotta wash this off, so the hassle factor is higher for these with an ileostomy. And sometimes they can leak if you don't have the clip in there, so these are more made for colostomies. But this is a soft skin type appliance for people who have sensitive skin, and there's a little vent here that keeps it from expanding, so it stays flat. And so there's, when the patient, I don't know what happens, but the patient, somehow the hospital triggers that a patient, to the medical supply companies, that a patient is having an ileostomy. So you get samples from everywhere, which is great. I mean, that's fine. I got samples from everywhere. So I got to try a lot of different kinds. I mean, I only have like a couple of different bags here, and then I have the two-piece, and then you have the, this kind, if you have a recessed stoma, it helps to have this kind of wafer that pushes it in more. Remember that one you saw where it was recessed in? I use this kind of wafer to keep the flow outside of that area. And so I like the two-piece system, it works good for me, but each patient is individual. So, and then the adhesive discs are a nice idea. The other thing is there's barrier, no sting stuff that you can put on there, and then skin prep, that's right, stop. Stop. Yeah, and then the adhesive remover, but again, this is tricky because if you use this, you might not be able to get the implants to stick, so you have to wash it right after.
So if somebody wasn't like in the medical field, would they normally have like a home care nurse go into their home when they first go home to kind of follow up with me, and did they just kind of once they're out of hospital?
They could have that, now that's you guys again. If you feel they're doing hands-on and they know how to do it, you're gonna do the teaching at the hospital, the stoma nurse and you guys. If you see that patient is not able to cut the wafer, or they're not able to get the bag sealed, then they're gonna need a home care nurse out there to help them, to do a reteach. So that's kind of gonna be up to you guys when you see how they're doing. But I don't think that's a normal, that's not a normal process where they send a nurse out for
I
that.
don't think so. I think more, like baby support groups out in the community.
It's the same one.
Why does this one stick up a little? Just post-op swelling or?
Yep.
Okay.
Yep. So another thing that really works good is this M9 is a deodorizer, and it's also an enzyme that breaks down the stool. So this is, I got some stool on here. Okay. Sorry about that. And then, some people, there's all different kinds of products. I just have a few of them, but there's Correa powder that you can put around the stoma that people use as a sealant. And then I use, interestingly enough, the stoma nurse told me to use Desinix, antifungal foot powder. They use that around the stoma for the fungus, and this really helped heal around my stoma. I could have never known that, but they use this a lot.
So you said that you do use the M9?
Yeah, I do.
So
I do it.
Okay, so, because I thought that it was going to have a smell to it, but it didn't.
No, I mean, I don't use it all the time, but, oh, I'll tell you.
Depends on what you eat.
My teenage boys would pound on the door in the bathroom for me to get out, and I'm like this, I'm trying to get, I would just, okay, let her rip, not flush, I'm done. They go in there, they're like, oh my God, Mom. And then I was in the hospital, I sent them pictures of my bag. With the, in the bag. God, you're sick. How do you think my stoma looks today? Yeah.
Oh my gosh.
So
okay.
you know you've had an ileostomy and you're used to it when you like can be eating, go in the bathroom, empty the bag, go back out and eat. You know, I mean, I just don't even think about it anymore. But when I first had it, oh, I thought, how am I ever gonna eat? You know, later on you adjust, but when I first had it, like the soup, if you eat soup, tomato soup, it comes out tomato soup because it goes out so fast. So it's really hard. I mean, patients really have trouble eating. They're not gonna wanna eat because they're emptying that stuff all the time. You know, like people say, do you wanna have pizza? And I'm like, no, I don't wanna